Welcome, everybody. This is the webinar co-sponsored by Physicians for a National Health Program in California and Healthy California for All on the Healthy California for All Commission report. What does it say? What does it mean? And what do we do about it? I'm Hank Abrons from the Bay Area chapter, and I want to welcome our three panelists. Carmen Comsti, Commissioner for the Healthy California for All Commission and Lead Regulatory Policy Specialist for the California Nurses Association and National Nurses United. Thank you for being on the panel, Carmen. And next we have Jim Kahn, physician, Emeritus Professor of Health Policy and Epidemiology at the UCSF Institute for Health Policy Studies. Welcome, Jim. And finally, thank you, Michael Lighty, for joining, President of Healthy California Now. I'm going to tell you about the format in a moment, but I think most of us know about the mass shooting in Texas that occurred just today, and I'm feeling in a bit of shock. And so I'm just going to have a short moment of silence so we can think about that. Our webinar time is limited to just 1 hour. So the format will be that for 30 minutes, our panelists will discuss the commission report. They'll each have about 10 minutes. And then in the second half, we'll go to your questions. Please submit your questions in writing using the Zoom Q&A function at the bottom or the side of your screen. Submit your questions in writing, and we will take the questions in order and as many as we can possibly fit in, hopefully all of them. We will not be using the chat function, so attendees are not able to chat with one another. That's so you can focus your attention on the screen and on the panelists. And a link to the webinar recording will be sent to you by email after the webinar is finished. So now it's time to go to our first panelist, Carmen.
Thanks, Hank, and big thanks to P&HP for putting this together tonight. I think it's certainly been a really long road since the Healthy California for All Commission was first established, and we started our work in January 2020. And I think along the way, many of you, and I think it's important to recognize this up front, many of you who are here tonight, I know work tirelessly to ensure that as a single payer movement, that we showed up to push the commission in a positive direction. And I think, time and again, many of you that are here, you came to commission meetings, you made public comment, and you talked about key policy issues being debated by the commission. And I think as a movement, we really did a good job at being in the thick of the policy debates. And I've said this before, and I think it really, really bears repeating. We rose the wonky challenge that was given to us, and we showed the governor's office, we showed the administration, the legislature, that we mean business with single payer, and that we know the policy, that we're serious, and that we're well researched, and that we have well principled responses to all of the arguments, bad faith and all, that we've heard for decades on single payer. And I think that's really, really important. That's an important win that we all should make sure that we recognize that we've done over the past 2.5 years. But then on the report itself, I think, in my final commission meeting comments and other pieces that I wrote on the commission, there are definitely some positives in the final report, and we should celebrate and promote those as a movement. But it's a big but, there are major fundamental shortcomings of both the report and the commission's work overall. And this is why, on the whole, I voted no on the final commission report, because I don't think that we met our statutory charge of providing a clear path towards single payer in California. But does this mean that we throw the baby out with bathwater? Absolutely not. But I think what it means for us as activists, as a single payer movement in California, is that we have to be honest with what's in the report, both good and bad. First things first, there wasn't a clear endorsement of single payer from the commission. What we got was a bunch of muddy debates on policy and no real clear next steps. And I think the lack of clarity is really entrenched in the lack of basic definitions, which led to a persistent conflation of single payer with a system that includes a role for risk-bearing health plan intermediaries, which, as we all better know as health insurers. And because of this lack of clarity and the lack of foundational definitions in the final report, we get really muddy recommendations. And, if we want to take this metaphor further, mud on the path of single payer is not a good thing. And clarity is not something I would associate with the final report. So just keep this in mind when we're talking about the report and what we need to do as a movement moving forward. But first, to name some of the positives, we have yet another economic analysis among dozens of others saying that single payer saves money overall, and it could do so while covering everyone with comprehensive benefits, including long-term services and supports, and without copays, without deductibles, and without other cost sharing. Now, a lot of this is buried in the data tables that supplement the final report. So, what happened with the analysis is that there are several scenarios that the consulting team looked at on behalf of the commission. And by year 10, a single payer system, which is called a direct payments model in the report, a single payer system with long-term care and no cost sharing would save California between 23 billion and 72 billion with a B each year when compared to our current system. And then over those 10 years, California would start saving money relative to the status quo with the long-term care direct payment scenario by year 3. This isn't in the final report, it's in the data table. So just to be clear. And importantly, a single payer direct payments model would also cost less than a model that includes a role for health plan intermediaries. And we should use this and remind the politicos that talk about alternatives to single payer, that in every single scenario considered by the commission's consultants, a system that includes a role for health plans or other risk-bearing middlemen will cost more and provide less care than single payer. Another major set of positives in the final commission report, I think, are the 2 legal appendices, one on federal waivers and one on ERISA. One of the claims that I know a lot of us have heard is that state single payer is a legal impossibility and that federal law needs to be changed by Congress. The 2 legal appendices demonstrate that state single payer is not a legal impossibility, that we don't need a new law on federal waivers to get Medicare funds into a state system, and that we don't need a new law on ERISA to change how employer health plans are regulated. And simply put, we have reasonable legal arguments to make under current law without needing Congress to pass a new bill on federal waivers or ERISA, point blank. Of course, there's legal intricacies, but these 2 memos really support going forward with single payer without having to go to the lovely folks in Capitol Hill. And one other important positive in the commission process is the community engagement report, which very clearly demonstrates the sheer level of support that we have for a single government-run healthcare system in California, with nearly 2/3 of low-income Californians supporting it. Even more so with communities of color who strongly emphasize that they want to be involved in healthcare redesign and they want to have decisions about their own healthcare, not insurers or middlemen. And I think these are all really important victories to push and emphasize when we talk about the commission. Now, on the gaps of the report, I think first things first, single payer is barely whispered in the final commission report. If you read the report without having too much context about the commission and our deliberations over the past 2.5 years, you might not know that we were charged with providing a path towards single payer in California. Now arguably the discussions throughout the report about the direct payments model are about single payer, but a lot of you might know, and if you've watched commission meetings, I've complained about this a lot over the past 2+ years, but the commission and our consultants who wrote the report, we didn't do our basic job in the foundational work and giving clear definitions to key terms like unified financing or single payer or direct payments or intermediaries. And this is why everything's just lumped together as one thing. So what happens is that the report talks a lot about a model with a role for health plans as risk-bearing intermediaries, but it drops the ball on having sufficient critical analysis about it. And to be clear, any system with risk-bearing health plans is not a single-payer system, and we shouldn't accept it as such. Making health plans and providers bear the financial risk of the provision of care entrenches profit-taking in our healthcare system, because insurers, hospitals, clinicians, they will be incentivized under a risk-bearing model to limit and deny care because it will affect their pocketbooks. What ultimately happens in the final report is that single payer is wrongly conflated with these profit-driven health plan systems under the umbrella term unified financing. So what this means for the single payer movement is that we need to stay on top of the ball to frame the wins and the positives of the report, to clear the mud, if you will. And the report, when it attempts to put single payer on the same footing as the system with health plan middlemen, we have to push back on this. The numbers in the economic analysis, like I said earlier, make it really clear that a system with health plan middlemen costs more and provides less care than single payer. Politicians might not know this if they don't open up those Excel files, so we need to remind them of this. On the larger scale, the report doesn't, presents a lot of the reforms under our current system as prerequisites to single payer, and we also need to push back on this. We need to make sure that the administration moving forward on unified financing, that they hear the criticisms that I and other commissioners have raised on the use of risk-bearing health plans and other middlemen, and keeping them accountable to what a single payer system actually is. At the end of the day, the commission's report, despite its shortcomings, does provide some critical tools to rebut long-held excuses from disingenuous politicians. But if politicians attempt to use the commission's report as a reason to support reforms around the edges of our fragmented health insurance system rather than supporting single payer, by all means, use my no vote as a corrective to those politicians. Tell them the things that we've been saying as a movement to correct some of the things that have been said about single payer. But I think the last big thing I want to just remind folks of, and I'll hand it back over to Hank. As with everything, we need to organize, and we need to organize again, and we need to organize some more so that we can ensure that the positives of the commission report are rightly observed and that any of the shortcomings are corrected. We need to be on top of the ball to make sure that the good things come out of this, of the commission, and that it's not used as another excuse to kick the can on single payer. And with that, I will give it back to Hank.
Thanks so much, Carmen. You've given us a lot to think about. I want to get Jim's comments, and Jim, I'm going to be really interested in your analysis of the economic findings of the report.
So first of all, I want to thank Carmen and all of the other commissioners and the state and the consultants for all of the incredibly hard work over the last 2 years. Before we started, we were talking about 4-hour Zoom calls, and I don't know how you did it, Carmen. So thank you very much for your hard work. And I also want to say that, I go way back as a single payer researcher and advocate. And so I agree with 98% of what Carmen says about the potential for resolving our healthcare financing problems with single payer and not with anything else. The single payer really is the best. And I just want to remind people that it was 20 years ago, almost precisely, that there was, I think Carmen, probably before you went to law school, there was a big state project which demonstrated the financial advantages of single payer that I participated in way back then, and nothing happened with it. So I think the critical issue is, for me, is what is the process going forward to learn from the commission's findings and proceed in a politically viable way. I don't know Governor Newsom. I don't know any of his close advisors. I do know from history that he is a risk taker in politics in a good way. He was responsible for gay marriage in the United States. And I hope that he sees this support for a real reform in this commission report that nudges him in the direction of taking that kind of a big chance to do the right thing. All of that said, I have a more upbeat assessment of the report than Carmen does. I would have voted yes if I was on the commission. And this is despite my very high single payer standard, if you will. And that's because up front in the executive summary, which is what 95% of the people who look at this report will review, the principles that are established quite clearly and in quite a nuanced but powerful way lead us to the conclusion, I think, that only single payer can achieve what's laid out. Let me walk through that quickly. All Californians will be entitled to receive a standard package of healthcare services. That is a huge statement, a standard package of healthcare services, not healthcare services that cover certain types of service of care. No, a standard package. I take that to mean everyone gets covered exactly the same. Entitlement will not vary by age, employment status, disability status, etc. Distinctions among Medicare, Medi-Cal, employer-based or sponsored insurance, and individual market coverage will be eliminated. This is massive. Every other country among the wealthy countries takes this approach. They have one standard, fully standard coverage package for everyone. And that is absolutely critical. And I don't see how you do that without single payer. The executive summary also notes that the total healthcare expenditures will come down. I think as Carmen says, it doesn't get into the differences between the scenarios that involve private insurers, but it does make the important statement that you can, even when covering long-term care services, you can bring down the costs. Another critical point of the summary for me is that the role of health plans is called out. It's not dismissed as hogwash, which it should be. It's clearly hogwash, but the wording is surprisingly good. Evaluate whether health plans under the status quo add value, whether they add value. That's a massive statement. By furthering access, affordability, equality, and equity, while accounting for excess administrative costs. So they're emphasizing right here in the executive summary that they impose excess administrative costs and profits and burden on providers. So our major critiques of risk-bearing for-profit intermediaries are echoed in this in the executive summary. It says, if health plans are retained and reimagined under unified financing, what functions would they perform? What functions would they perform? Again, it's unbelievably powerful in putting into question, or implicitly, they're saying that the current functions are quite possibly or probably problematic. I take, you know, these statements, I'm sure this executive summary was edited dozens of times, and that what it came out with, if we are to take it at face value, is incredibly powerful. Now, as Carmen says, the work must continue, must gear up. We have a lot of battles to fight to get the conclusions properly channeled into a really good single payer bill. I'll just finish by noting that for me, one of the critical steps is to further pursue the technical issues that were addressed incompletely by the commission, such as really digging down into what we pay for having these for-profit risk-bearing entities, and then going from there to talk about whether and under what conditions it would be acceptable to have a not-for-profit intermediary, a not-for-profit health plan. This is a subject of very energetic debate, both here in California and nationally. I have been in this debate. I happen to think that if we can get across the finish line and allow for capitated integrated plans that are not for profit, that is an acceptable situation to contemplate. Some single payer advocates would I think oust me from the single payer community for even uttering those words, but that's, after I've thought about it for a long time, that's what my thinking is. Another issue is payment methods. What's the role of fee for service, fee for time as a way to play doctors? How do we do global budgets? Again, do we allow capitation? Do we permit any cost sharing? There are two schools of thought. One is absolutely not, none. And the other is we can save a little money if we have some limited cost sharing for wealthier individuals. What do we do about keeping prescription drug prices down? What do we do to simplify the formulary mess that we have so that doctors don't have to juggle all these different formularies? And perhaps the most challenging, well, for me, for sure, is the question of, are there building blocks that move us towards single payer short of single payer? I think the term sequential steps came up in some commission discussions. Are there steps that can be taken? For example, collecting much better information about how much is currently being spent and setting up mechanisms for unifying financing. Are there steps that will lead us towards single payer and not just serve as another stalling tactic or another diversion from what I think we all agree has to be the goal of getting to single payer? So there we are. I was very worried about what would come out of the commission, but due to Carmen's hard work and the work of other single payer advocates on the commission, and as Carmen pointed out, the single payer community, there are many strengths to this report, and I think on balance, it gives us a really good platform to forge ahead. That's it.
Thanks, Jim. And Michael, it's your turn.
All right, thanks, Hank. And I just want to start out by thanking Carmen as well for what was really at times a lion's den scenario. And I thought that your advocacy was instrumental in shaping the final report, and also making sure that it didn't endorse some of the most problematic aspects of what arguably you could look at some of those commissioner surveys and say, well, there's a lot of agreement on stuff that we don't like. And I think the final report, actually, the fact that it is vague in some respects does reflect well, particularly on your work. And I think also Dr. Galley, the Secretary of the Department of Health and Human Services, once he took control of the commission process, it became much more productive. And I think he deserves a lot of credit. And I think there's a number of other commissioners acting in very good faith that contributed to a very useful report. I mean, let's just reiterate the top lines. I mean, up to $500 billion in healthcare savings over the next decade. And those savings could be put into long-term support services and still achieve hundreds of billions of dollars of savings over that period of time. As much as we're going to spend as much as 158 billion more if we just keep the present system in place by the year 2031. This completely shifts the debate. The notion that we have to debate whether we can afford single payer is transformed into how can we afford not to do it? And the onus of this official report and analysis, the imprimatur of the California state government to opponents of single payers, okay, where are you going to come up with that 158 billion in $22? It's on them. And I think the report makes pretty clear that the proposal, I think we should own, it's not specific enough on single payer. It does talk about direct payments. It talks about the costs of unwinding managed care if we go to a direct payment system. I tend to think that when they talk about unified financing, we should assert that that's the only thing that could possibly mean and achieve, as Jim says, the objectives that the report lays out for a new system is single payer. Now, we're also, of course, talking about saving 4,000 or more lives annually by going to this system of what we call guaranteed healthcare. It's quite extraordinary that the report description of the present system is so damning in terms of its fragmentation, its waste, how it disproportionately harms low-income and communities of color, and it provides a rationale for the new single government administrative funding system. That basically that we can deliver care equitably, universally, and eliminate all barriers to receiving that care under, I think, as Jim pointed out, a single standard of care. These are long-held objectives, and I think the official imprimatur of this report is very helpful. I would agree that as we dive into some of the policy details, it does raise the question of which side are we going to come down when we actually design the system? But let's keep in mind, these were always political questions. And I agree with Carmen that the problematics of risk-based capitation are not really sufficiently put forward in the report. And there's a lot of lip service to assumptions about the value of some of these managed care practices, which are actually quite detrimental to people getting the care they need. But if you start at the principle level that every Californian gets the healthcare they need and deserve, then I think you find within the body of the report those elements that point toward the necessity of single payer as the financing approach. I do think I'm a little more optimistic probably on the next steps. I think that it's significant that There was a budget request in the May revise for resources in the amount of $368,000 in the next general fund to hire at least the equivalent of 2 health program managers who can to make additional progress toward unified financing and develop and implement a federal partner engagement strategy to understand what the federal approvals needed. And in addition to that, there's a request for $1 million for contracting for research and consulting services. So I don't think the state in the past has ever committed resources to actually figuring out how we're going to get federal waivers, what it's going to take, and committing resources to actually doing the kind of research and analysis that's necessary. That is a huge step forward. I tend to think that Health for All, covering undocumented folks, is progress. It's under Medi-Cal. The problems with Medi-Cal, obviously, is that it's riven by some of these for-profit managed care organizations, but 17 counties are going under the current reform program to a public plan program, and that's progress. And I think that having that progress made, taking that issue of covering undocumented folks off the table politically is hugely beneficial. I agree. Let's see what we can do in terms of setting up structures that lay the groundwork for rate paying and others. I'm not sure that the current bill, AB 1130, does all that. Probably doesn't, in fact. But I think we've got to look at those steps that can start building the infrastructure to make single payer viable. And that's ultimately, I think, my conclusion is this is a political process. This report was never going to resolve these questions. But the fact that it takes such a fundamentally critical perspective on the current system, that it does, as Carmen said, lay out that we can actually implement single payer without this smokescreen of additional congressional authority, without the distraction of using the RISA, the Employment Retiree Income Security Act, as an excuse not to do it. That is quite significant, I think. And what this does is essentially throw it back to the legislature to say, okay, you've got clearly elements in this report that point the way toward the only system that's actually going to guarantee healthcare on an equitable basis that eliminates the barriers disproportionately affecting these frontline communities of color and low-income folks in California. So the onus is on them to create a systems design that can win federal approval and then be ultimately enacted by the voters. So we were not going to resolve these issues of payment methodologies, per capita payments, for example, global budgeting, and the role of fee for service in the commission. And we're in some ways, I think, fortunate that the commission didn't come down on those questions, because the chances of them coming down on the wrong side were pretty good, given a lot of the stuff that we heard during those debates. One thing that hasn't been mentioned is that there's great attention paid to workforce issues, investing in support of workforce that's diverse and that meet the cultural, socioeconomic, and linguistic diversity of California residents, because there were two things that stood out in that community survey. One was the fact that this overwhelming support for a government-run single-payer system, and the fact that financial barriers to care were the biggest problem facing low-income Californians. And secondly, that those Californians don't get care in a system currently that respects them, that provides dignified care, and that is culturally competent. And so we do have to address both those aspects of it, and the report makes that very clear. I tend to think that our political fight is what it is, and certainly during the struggle over AB 1400, many of those same issues came to the fore about what kind of role for health plans and intermediaries. I tend to agree with Jim that we've always said that care coordination, and particularly the role of primary care providers, physicians in particular, is central to making sure that people can actually navigate a complex healthcare systems based on their individual patient needs. And that there was actually quite a bit of support for that approach. So I thought that was encouraging. Care coordination is not the same thing as risk-based capitation. There was quite a bit of confusion. Again, I think Carmen is right that they muddied the waters on a lot of this stuff. But if we can design a system that doesn't have any place for the money to go, even a nonprofit system, Kaiser makes $4.1 billion. That's got to end, because if they have an incentive to generate net income for their own capital expansion, that's not going to work. So there really has to be a system in place where there's no place for net income, excess revenue to go, and therefore end any kind of financial incentive to deny care. And I do think the report came down strongly against such financial incentives. So there's obviously a lot to digest. I think the bottom line is this: if we organize effectively, this is a catalyst for creating a single payer system of guaranteed healthcare in California.
Thanks, Michael. And now we're at the turning point where we're going to take some questions from the audience. And I'm going to do my best to paraphrase some of the questions, but a lot of them have to do with the final question that we pose to you, which is, what do we, the single payer proponents, do now? And here's one that refers to the fact that significant social change requires, at a minimum, broad labor movement support. The labor movement is a key component of the movement for social change. And the questioner points out that labor in the broad sense was not invited to take part in drafting the bill. So the question is, in redrafting bills yet to come, will broad labor have a place at the table, including the Kaiser unions?
Yeah, I think, Hank, I think that was directed at me and CNA. So, just to kind of, of course, CNA will and has always worked with the California Labor Fed on its legislation. And I think, generally, CNA is a labor union, and we try to work with our fellow unions to put together a good package for single payer bills. And, we've been working tirelessly to get more unions into the fold for single payer and the California Labor Fed. And we're also exploring options on setting up a legislative caucus like we have with Medicare for All on the national level, to make sure that we have all those connections. A lot of this with the legislative process generally, a lot of this will ultimately depend on how our labor leaders want to proceed and move forward on single payer and the bills, and who we end up talking to with legislative sponsors. But generally, of course, we want more folks to be involved in drafting the legislation and putting together ideas. And this is about a big process, and making sure that what we're saying at both the national and state level are very similar. So there's a lot of moving parts. No one's excluded, and we're trying to build in more processes to have more voices involved in the legislative drafting process.
I would just add quickly, Hank, that I do think one of the advantages of the commission report is that it points toward a process where we engage with the governor's office as they pursue federal discussions, that we engage with the public, because of course there's public comment required as part of seeking the federal waiver, and we engage in the legislative process to come up with and answer these key system design questions, which are in their lap. And so I do think, I certainly take Carmen and CNA's good faith in really having a process that's inclusive, because what the report shows us is that we're going to need every institutional and organizational supporter engaged in this fight if we're going to move the legislature to our program. And we are going to have to resolve some questions that are contentious, like the role of integrated healthcare systems, like Kaiser, like community clinic consortiums, and some of the policy details that obviously are vexing in some ways. So I do think that if we take seriously the context provided by the report, it naturally leads to a collaborative process among advocates, and we can ultimately probably come up with a process that gets us the systems design, gets us the federal waiver, and then gets us the broad base of support that we're going to need to win a ballot initiative.
This is a question, I think, mainly for Jim. The questioner wants to know how you define nonprofit in healthcare. And the questioner feels like there's some complexity in how that is done. Can you comment, Jim?
Well, first of all, I'm not a lawyer, so the legal ins and outs of it I leave to lawyers. Secondly, I will note that the designation or the corporate structures can be highly deceptive. You can have a not-for-profit overall corporation with for-profit subsidiaries, and I think that's a perversion of the notion that it's a not-for-profit. But most importantly, I want to echo something that Michael said. What we want to do is remove incentives for organizations to not spend all the money that they receive on healthcare. Whether an organization is for-profit or not-for-profit, if they can save money and then use it, say, to build another hospital, as Kaiser does, that is simply not consistent with what single payer is about. And the mechanisms to remove those incentives have to do with who is permitted to own the organization, i.e. shareholders or not, has to do with who makes decisions about capital spending and where that money comes from. And also, I think it goes to the issue of executive salaries. And if executives can earn $10 million by saving some money on patient care, that is an equally corrupt incentive. And so I think the question is a really good one, but I think the answer has to do with looking beyond any narrow definitions of for-profit and looking at incentives to profit financially, whether it's called a salary or a capital investment or the traditional definition of profits for shareholders. Again, not a lawyer.
Carmen, do you want to make any additional comments?
With nonprofit regulation in the healthcare sphere, I think it's good to remember, and I think I've said this a couple of times on at commission meetings, is that being a nonprofit is and corporate structures are legal fictions. Nonprofits they are still required to to meet the fiduciary duties of their corporate entities. They are corporations. So I think it's always good to remember that in order to take the profit motive out of nonprofits, and remember, all these giant health systems that many of us in labor unions from that fight against every single day because of their profit taking at the expense of healthcare workers, from Kaiser to Sutter to all of the big players, to HCA, all the big players. Those are all, well, not HCA, bad example, but Kaiser and Sutter, they're nonprofits. So, I think when we're talking about intermediaries and trying to regulate health plans or other types of corporate healthcare structures that are nonprofits, that there's still a profit incentive. It just doesn't go to stakeholders. And I think that's the trouble of trying to find some regulatory field in terms of the legal aspects on how to do this, because really at the end of the day, the threat that the state has for regulating these entities is to take away their nonprofit status, which, you know, they'll find ways to not pay the taxes, even if they somehow are able to convert them to for-profits. I'm going off on a little tangent, but yes. So I think generally it's very difficult to target nonprofits in that way.
Here's a pair of related questions that I think are for all three of you, if you can just comment briefly. So one part of it is that the questioner says, so many bills have come and gone. How do we know when we're going to have the votes? If we have a bill and don't have the votes, that may be demoralizing to our movement, and what impact does it have on our credibility with the public? So this certainly was a question that applied to AB 1400. And then a slightly related question is the question of the merits of advocating simultaneously for single payer legislation at the state and the federal levels versus favoring one in front of the other. Michael, do you want to go first on that?
Sure, I'll jump in. Look at this is again the opportunity presented by the commission report that, you know, the one big bill approach hasn't succeeded. Either it was vetoed by the governor, or it was stalled after it got through the Senate, or now was not able to get out of the assembly. So that's our recent history. We've, you know, at Healthy California Now have maintained that governor leadership makes the difference. And what we're seeing at the federal level is that the president's position to Medicare for All seems to have foreclosed a short-term political path to win Medicare for All nationally. And that has put more emphasis on the states. Every single payer activist I talk to who is at least open to state-based organizing believes that California is the best hope for establishing a model for single payer that can have political momentum to be enacted federally. So the symbiotic relationship continues between state and federal work because we're addressing the similar issues, we're organizing similar constituencies, and we're taking on similar opposition. And the message environment matters. We haven't discussed it here much, but ultimately we're going to have to be able to prevail over, you know, probably a $200 million industry campaign against us. And so our process of using the legislation at the state level and using the federal fight to inoculate and educate voters is central to our ability to win. So I do think that, you know, prioritizing one over the other doesn't necessarily work. We saw with the introduction of Senator Sanders' bill, 15 senators on a bill. That's a very good sign. And we haven't eroded. But of course, in California, Senator Feinstein isn't on that bill. She should be. This is a state that strongly supports this reform. Who does she represent? She represents the healthcare industry. That's a political opportunity for us, and it again utilizes the symbiotic relationship between state and federal work. So I do think that if we take clearly the opportunity presented before us, we're going to find a path towards single payer that will enhance our credibility, because our demands have been, I think, enhanced by the commission report to begin with.
Carmen, you next.
Yeah, I would also add, you know, legislation it's a very powerful tool to build power as a movement, and I think that's really important to recognize. Is it always going to be the answer in and of itself when we don't have the votes? No, but I think introducing a bill and making sure that we have it on the table, that it's being discussed, is really, really important. You know, I don't want to relitigate what happened with CalCare, but I think, there are a lot of lessons that we can learn from previous bill introductions, and we know that we have to have some discussion to build the tools of the movement, to build the visibility of the movement, to get people in front of legislators. And it's much easier to do that when there's a bill introduced and than when there's not. And I think as someone who's done a lot of first visits with people who are have never done lobbying before, it's a very powerful thing to have someone go to a legislator and see them as a real person, to see that that you are their bosses. And it might seem a little bit romanticizing of the legislative process, but I think it is really important to have those first types of engagement and contact with legislators, to know that this is how the process works, and this is how we engage, and this is how we can build a movement. And I think from the commission, we've really shown that getting people out there, getting all of you folks out there to talk about the policy of single payer is really important. Individuals can't win this, and a movement has to win this. And it's important that everybody engage on all levels. And sometimes there'll be setbacks, like there was when the CalCare bill was not put to the floor of the assembly. But I think it takes time. Movements take time, and we just have to keep on organizing. And I think it's really important that we use every opportunity that we can to keep it moving forward.
I will keep my comment brief, Hank. First of all, I'm not a political tactician, and I defer to Carmen and Michael and the others who know something about that. It seems to me we don't want to foreclose national or state options, that we want to be probing wherever we can. But my more sort of general comment is, I've come to believe that getting single payer is a revolution. It's not just a better way to pay for healthcare. It will change our society in profound ways. We're talking about removing control of nearly 1/5 of the economy from blood-sucking profiteers and guaranteing that everyone has lifelong, high-quality access to healthcare. I think that will change how our country operates and how people think, and it may break the profoundly disruptive logjam we're in now, may bring many from the right who are on the right because they're so anxious about their lives, including their healthcare. And so I think as with regular tactics, political tactics, I think revolutions come from different places, and we just don't know. No one has gotten single payer in the United States. So I think the answer is, from my standpoint, again, not being a lawyer or a tactician, is let's continue to probe the possibilities both nationally and in states.
I'm not a tactician either, but every time I've read about a revolution, it's always followed by a counter-revolution. So we need to get ready for that. After we
already had the revolution on the right, now we need the counter-revolution from the left.
So we're coming toward the end. We have about 5 minutes left, and there are several questioners who noticed in the report its mention of the Office of Healthcare Affordability. And I think this is the bill that has been championed by Assembly Health Chair Jim Wood. And PNHP California has had discussions about this, and we notice the lengthy time frame and the fact that it seems to ask the question whether we can get control of healthcare costs as a prerequisite or predecessor for going to single payer, and the feeling that actually that's the wrong order, that we go to single payer and then we have really addressed the major question in affordability. So I think behind this question is this piece of legislation really a fig leaf to delay single payer, or is it something that we should view as being constructive? Michael or Carmen, either one of you.
I'll go ahead. Look, we have to understand that this legislation, to the extent that it has elements that might be progressive, derived from the union health plan's experience and desperation in trying to maintain benefits that they can make sure that their members can access. And so this reflects the problems of the current system and the particular problems that union health benefit funds have to deal with. And it reflects the consolidation of control by corporate hospital chains that Carmen was mentioning, as well as the power of insurers and prescription drug companies to charge wherever they want. And I agree, single payer is the way to control costs. If we can set up a foundation for rate regulation and the basis to understand how best to accomplish that, all to the good. But it is by no means a fig leaf in the sense that there are, people who support single payer but who want immediate relief. I think the timeline of this bill has been extended to the point where its benefits are somewhat questionable. And the benefits themselves just structurally are questionable, particularly in relation to single payer. So I think there are real questions about it, but we have to understand that there are allies in our movement who are going to spend some time trying to make that happen. And that's really the political task. We've consolidated the progressive constituencies in California, but the institutions and organizations that are up lobbying on healthcare reform every day in Sacramento are not yet committed to the single payer movement and our project. That's one of our key tasks, and that includes unions. So to me, this is really part of the movement building, is building that institutional organizational support, recognizing why some of those allies are engaged in more of this incremental work and bringing them to the point where, yeah, okay, that's great, but if we really have single payer on the table, let's focus on that.
Yeah, I would just add that I think particularly with the Office of Healthcare Affordability, I think it's important, and this is underlies one of my criticisms of the final commission report, is that there is a lot of confusion about, are these types of incremental reforms prerequisites to single payer? And I think it's important for us to clarify that no, they aren't, and that they'd actually, the Office of Healthcare Affordability would be much more successful if single payer was in place to help with issues of affordability and looking at how to control rate setting, because we're not going to get the same effect when we're negotiating against a number of health insurers. So I think it's really important for us to make sure that we're clear that we don't need the Office of Healthcare Affordability or these types of other incremental reforms of health insurers to get to single payer. And I think it needs to be clear that that there wasn't any endorsement of a sequentialization of these different types of steps in the actual final commission report. And I think that is one of the things that really worries me about what was written in the commission report, is that it could be misinterpreted and misconstrued. And I think it's really important for us to make sure that message isn't given across to folks who are pushing for these other types of reforms. And I think one of the other questions that came in was very similar in terms of, and I think this has come up in the commission several times, where other commissioners describe reforms of Medi-Cal as some sort of move towards single payer. Of course, expanding Medi-Cal is an incredible and an important thing to do in the short term, but it does leave a whole bunch of people out of coverage. And any means tested system would do that. But it's important to remind ourselves that if there are other folks who are pushing for other types of reforms, that is not going to ultimately solve the problem. And I think we need to be very clear and upfront about that, about the limitations of these types of other reforms, and to say that we are not going to accept those as an alternative, particularly if they take away the attention of administrators or legislators from doing other work. So for legislators, I would tell them, walk and chew gum. Fine, you can support your Office of Healthcare Affordability bill, but that should not preempt any types of other work on single payer legislation. They shouldn't be mutually exclusive. You can do this at the same time.
I wish we had more time to hear more from the three of you, and also to address a lot of good questions that we aren't going to get to today. But Jim, do you want to have a last word? It needs to be brief, because it's 8:02.
No, I will stand with whatever I said before.
Okay. Well, thanks so much to all three of you. And I want to close by thanking Healthcare for All California for co-sponsoring, and for the many activists in both organizations and beyond who helped to spread the word and to publicize this webinar. And I want to thank the PNHP national staff for assisting and supporting putting on this webinar tonight. And finally, to the participants, I hope you found this worthwhile. And if you'd like to have more meetings like this, and if you have a topic to suggest, please send an email to PNHP California. And our email address is pnhpca@pnhp.org. So with that, good night, everybody. Thank you again.
Thank you, Hank. Thank you, Matt. Thanks for putting this together. Appreciate it.
Yes, thank you, PHP. Thank you all for doing it.
Good night.